Hello, everyone, and welcome to today's lecture on fluid, electrolyte, and acid-base imbalances. My name is David, and in this session, we're going to break down the essential concepts you need to know to understand how the body regulates fluids, electrolytes, and acid-base balance. These are critical areas in nursing practice, since imbalances can be life-threatening if not recognized and managed early. We are discussing Chapter 17 of our book, Lewis's Medical Surgical Nursing, Assessment and Management of Clinical Problems. We'll start by looking at three main categories of imbalances: fluid imbalances, such as dehydration or fluid overload, electrolyte imbalances like hypernatremia or hypokalemia, and pH imbalances, which can lead to acidosis or alkalosis. Each of these conditions affects the body differently, but all of them can disrupt normal physiology and must be managed carefully. Sometimes the body isn't able to compensate for these imbalances. For example, in acid-base imbalance, either the lungs or kidneys have not responded adequately to correct the pH. In electrolyte imbalances, the abnormal levels of sodium, potassium, or calcium remain uncorrected. We call this an uncompensated state, and it often requires urgent medical intervention. Water makes up about 50 to 60% of an adult's body weight. This percentage varies depending on age, gender, and body mass. Remember that water is the medium in which nearly all body processes occur, so maintaining balance is essential. Our body fluids are divided into two major compartments: intracellular fluid, which makes up about 2/3 of total body water; extracellular fluid, which includes interstitial fluid and plasma. Understanding these compartments helps us recognize how fluid shifts can affect a patient's condition. Electrolyte movement between intracellular and extracellular fluid is crucial for homeostasis. Diffusion allows electrolytes to move from high to low concentration without energy. Facilitated diffusion uses protein carriers for large molecules, also energy-free. Active transport, like the sodium-potassium pump, requires adenosine triphosphate to move sodium out and potassium into cells against the gradient. Osmosis involves water moving from areas of low solute concentration to high concentration across a semi-permeable membrane. This movement is influenced by hydrostatic pressure, such as blood pressure from heart contractions, and osmotic pressure, driven by large molecules like proteins in the blood. Understanding the difference between hyper and hypo is crucial. Hyper indicates an excess, such as hyperglycemia, where blood sugar is too high. Conversely, hypo signifies a deficiency, like hypoglycemia, where blood sugar is too low. Recognizing these prefixes helps in diagnosing and managing various medical conditions effectively. Water balance is crucial, requiring 2,000 to 3,000 milliliters per day to offset urine and insensible losses. Sources include oral intake, food, and metabolism. Insensible loss occurs via vaporization from lungs and skin, while sensible loss involves exercise or fever. Hypothalamic pituitary regulation ensures balance, adjusting for increased needs due to metabolism, fever, or exercise. The posterior pituitary releases antidiuretic hormone, increasing the kidney's distal tubules and collecting ducts permeability, enhancing water reabsorption and reducing urine output. This mechanism restores fluid volume. Thirst and antidiuretic hormone release are triggered by fluid deficit or increased plasma osmolality, crucial for maintaining water balance. Vulnerable groups, like unconscious patients, face higher dehydration risks. The kidneys regulate fluid and electrolyte balance by adjusting urine volume and excreting electrolytes. They filter plasma multiple times daily, reabsorbing about 99% of the filtrate, resulting in approximately 1.5 liters of urine per day. Hormones like antidiuretic hormone and aldosterone control water and electrolyte reabsorption, maintaining plasma osmolality, blood volume, and acid-base balance. Severe dysfunction can lead to edema and electrolyte imbalances. Adrenal cortical regulation involves glucocorticoids and mineralocorticoids. Glucocorticoids, like cortisol, increase serum glucose and can cause sodium retention. Mineralocorticoids such as aldosterone promote strong sodium retention and potassium excretion, enhancing water reabsorption. These hormones are controlled by renin-angiotensin-aldosterone system, serum potassium, sodium, and adrenocorticotropic hormone, crucial for maintaining fluid balance and osmolality. Natriuretic peptides, including atrial natriuretic peptide and B-type natriuretic peptide, are secreted by cardiomyocytes in response to increased atrial pressure and serum sodium. They act as natural antagonists to the renin-angiotensin aldosterone system, suppressing aldosterone, renin, antidiuretic hormone, and angiotensin II. This promotes sodium and water excretion, ultimately reducing blood volume and blood pressure. The GI tract secretes about 8 liters of digestive fluids each day, and most of it is reabsorbed, with only a small amount lost in feces. When vomiting or diarrhea occur, this reabsorption is reduced, leading to significant fluid and electrolyte losses, which can quickly cause dehydration. Fluid volume imbalances can manifest as deficits or excesses. When the balance is disturbed, patients may develop fluid volume deficit or fluid volume excess. Fluid volume deficit or hypovolemia results from abnormal fluid loss due to diarrhea, vomiting, hemorrhage, or polyuria. Conversely, fluid volume excess or hypervolemia arises from excessive intake or conditions like heart failure and renal failure, leading to weight gain. Understanding these imbalances is crucial for effective management. Assess patients for fluid imbalances and risk factors, ensuring they can manage hydration. Administer intravenous fluids, medications, and oxygen as ordered. Implement fall precautions and provide a suitable diet. Initiate referrals to dietitians or occupational therapy if needed. Monitor therapy effectiveness. Supervise daily weights, vital signs, intake output, skin care, and encourage oral fluids. Electrolytes are crucial for maintaining homeostasis, influencing fluid balance, nerve function, and muscle contractions. Key electrolytes include sodium, potassium, calcium, and magnesium. Imbalances can lead to serious health issues, requiring careful monitoring and management. Understanding sources and roles of each electrolyte is essential for effective patient care and prevention of complications. Sodium levels should be maintained between 135 to 145 milliequivalents per liter. Sodium is crucial for maintaining extracellular fluid volume, nerve impulse transmission, muscle contractility, and acid-base balance. Common sources include table salt, processed foods, and pickled items. Understanding sodium's role is essential for recognizing imbalances and their effects on health. Hypernatremia occurs when sodium levels exceed 145 milliequivalents per liter, leading to symptoms like thirst, restlessness, irritability, and muscle twitching. Severe cases may cause confusion, seizures, or coma. It often results from inadequate water intake, excessive sodium intake, or water loss due to conditions like diabetes insipidus or diarrhea. Hyponatremia occurs when sodium levels fall below normal, leading to symptoms like headache, confusion, seizures, and muscle cramps. It can result from conditions such as heart failure, kidney disease, or excessive water intake. Treatment focuses on addressing the underlying cause and carefully correcting sodium levels to prevent complications. Potassium levels, normally 3.5 to 5.0 milliequivalents per liter, are crucial for fluid balance in cells and muscle contraction. It aids in carbohydrate and fat breakdown. Key sources include fruits like bananas and avocados, vegetables such as spinach and potatoes, and foods like bran cereal, chocolate, and yogurt. Hyperkalemia, an elevated potassium level, can lead to muscle weakness, fatigue, and cardiac arrhythmias. Severe cases may cause life-threatening conditions like ventricular fibrillation. Monitoring and managing potassium levels are crucial to prevent these manifestations and ensure proper muscle and heart function. Hypokalemia, a condition of low potassium levels, can lead to muscle weakness, cramps, and arrhythmias. It often results from diuretics, diarrhea, or inadequate intake. Monitoring and managing potassium levels are crucial to prevent severe complications. Treatment typically involves oral or intravenous potassium supplements, depending on severity. Administer intravenous potassium chloride cautiously. Always dilute, never give via intravenous push or bolus, and use an infusion pump. Limit infusion rate to 10 milliequivalents per hour unless under critical care. Hourly assess intravenous site for phlebitis and infiltration. Monitor urinary output and cardiac rhythm closely to ensure patient safety. Report hypokalemia symptoms to healthcare providers and check serum potassium levels regularly. Include potassium rich foods in your diet, moderate alcohol intake, and avoid excessive licorice. For those on oral potassium supplements, follow prescriptions, take with water, and avoid crushing tablets. Calcium is crucial for bone and teeth structure, blood clotting, nerve impulses, and muscle contractions. It is primarily sourced from diet, requiring active vitamin D for absorption. Of the 1,200 grams in the body, 99% is in bones. Plasma calcium is 50% protein bound, 40% ionized, and pH affects its binding and ionization levels. Hypercalcemia occurs when calcium levels in the blood are above normal. It can result from overactive parathyroid glands, cancer, or excessive vitamin D intake. Symptoms include fatigue, confusion, and kidney stones. Treatment focuses on addressing the underlying cause, hydration, and medications to lower calcium levels. Hypocalcemia occurs when calcium levels fall below 8.5 milligrams per deciliter. It can lead to muscle spasms, tetany, and cardiac issues. Causes include vitamin D deficiency, hypoparathyroidism, and renal failure. Treatment involves calcium supplements and addressing underlying conditions. Monitoring is crucial to prevent complications and ensure proper calcium balance in the body. Phosphorus, the primary anion in intracellular fluid, is crucial for muscle, red blood cell, and nervous system function, and is mostly found in bones and teeth. It plays a role in adenosine triphosphate formation and glucose metabolism. Regulated by parathyroid hormone and kidneys, phosphorus levels inversely relate to calcium. Normal phosphate levels range from 3.0 to 4.5 milligrams per deciliter. Hyperphosphatemia occurs when phosphate levels exceed 4.5 milligrams per deciliter, often due to renal failure or excessive intake. It can lead to calcification in tissues and cardiovascular issues. Hypophosphatemia, with levels below 3.0 milligrams per deciliter, may result from malnutrition or alcohol abuse, causing muscle weakness and respiratory failure. Both conditions require careful management to restore balance. Magnesium, the second most abundant intracellular cation, is crucial for enzyme systems, adenosine triphosphate production, and sodium potassium pump function. It regulates blood glucose and blood pressure and is vital for muscle and nerve functions. Magnesium is primarily stored in bones and muscles, with absorption in the gastrointestinal tract and reabsorption in the kidneys, increasing when serum levels are low. For hypermagnesemia, stop magnesium sources and enhance excretion with fluids and diuretics if kidneys are normal, or dialysis if impaired. Use intravenous calcium gluconate for symptomatic patients. For hypomagnesemia, mild cases require oral supplements and dietary intake, while severe cases need intravenous magnesium. Monitor vital signs and reflexes closely and have intravenous calcium gluconate ready. Electrolytes are crucial for maintaining fluid balance, nerve function, and muscle contractions. Key electrolytes include sodium, potassium, calcium, and magnesium. Imbalances can lead to serious health issues such as arrhythmias or muscle weakness. Understanding their interactions helps in diagnosing and managing conditions like hypermagnesemia and hypomagnesemia effectively. Now we will move on to discuss acid-base imbalances. Maintaining a stable pH is essential for normal cellular function, and when this balance is disturbed, it can lead to conditions such as acidosis or alkalosis. The body maintains a delicate pH balance crucial for homeostasis. Acids from metabolism are neutralized by bases. Disruptions, common in diabetes, chronic obstructive pulmonary disease, and kidney disease, lead to imbalances. A neutral pH ranges from 7.35 to 7.45. Below 7 is acidic, indicating high hydrogen ion concentration, while above 7 is alkaline with low hydrogen ion concentration. The body's pH balance is crucial for homeostasis, with a neutral pH range of 7.35 to 7.45. Disruptions can lead to conditions like acidosis or alkalosis. Patients with diabetes, chronic obstructive pulmonary disease, or kidney disease are particularly susceptible to these imbalances, which can significantly impact their health. Next, let's look at respiratory acidosis. This occurs when the lungs cannot remove enough carbon dioxide, leading to increased carbonic acid and a drop in blood pH. Common causes include hypoventilation from conditions such as COPD, pneumonia, or drug overdose. Clinically, patients may present with confusion, headache, or rapid, shallow breathing. Metabolic acidosis happens when the body produces too much acid or loses too much base, leading to a low blood pH and bicarbonate. Causes include renal failure, diabetic ketoacidosis, severe diarrhea, or shock. Patients may show signs like rapid breathing, confusion, and fatigue. For respiratory acidosis, nursing care focuses on improving ventilation. This includes maintaining a patent airway, giving oxygen as prescribed, monitoring ABGs, and assisting with breathing techniques or mechanical ventilation if needed. For metabolic acidosis, the goal is to correct the underlying cause. Nurses monitor vital signs, intake and output, and neurological status. Interventions may include giving intravenous fluids, insulin for diabetic ketoacidosis, or bicarbonate in severe cases. In both types, continuous assessment and prompt reporting of changes are critical to prevent complications. In respiratory alkalosis, the main issue is excessive loss of carbon dioxide, often due to hyperventilation from anxiety, pain, or fever. The patient may present with lightheadedness, tingling, or confusion. In metabolic alkalosis, the cause is usually loss of acid or gain of base, such as from vomiting, NG suctioning, or excessive bicarbonate intake. Patients may have muscle cramps, weakness, or dysrhythmias. For respiratory alkalosis, the priority is to treat the cause of hyperventilation, encourage slow, controlled breathing, provide reassurance for anxiety, and monitor oxygen and ABGs. For metabolic alkalosis, the focus is on correcting fluid and electrolyte imbalance. This may include administering intravenous fluids, potassium or chloride replacement, and stopping excessive suctioning or diuretic therapy. In both types, continuous monitoring of vital signs, cardiac rhythm, and lab values is essential, along with patient education to prevent recurrence. Here's a comparison of both conditions. Acid-base balance is assessed through arterial blood gas ABG analysis. Key normal arterial blood gas values include a pH of 7.35 to 7.45, partial pressure of carbon dioxide ranging from 35 to 45 millimeters of mercury, and bicarbonate levels between 22 to 26 milliequivalents per liter. These parameters are crucial for diagnosing and managing acid-base disorders. The body maintains acid-base balance through three mechanisms: the buffer system, which reacts immediately, the respiratory system, which adjusts within minutes to hours, and the renal system, which takes hours to days. These systems work together to keep the pH between 7.35 and 7.45, ensuring optimal physiological function. The ROME mnemonic helps remember acid-base imbalances, respiratory opposite, metabolic equal. In respiratory imbalances, alkalosis shows high pH and low partial pressure of carbon dioxide, while acidosis shows low pH and high partial pressure of carbon dioxide. For metabolic imbalances, alkalosis presents with high pH and high bicarbonate, and acidosis with low pH and low bicarbonate. Now, I will help you to make your own graph. In acid-base imbalances, remember ROME. Respiratory conditions show opposite changes in pH, and PaCO2, while metabolic conditions show equal changes in pH and HCO3. For respiratory alkalosis, pH is high and PaCO2 is low. For acidosis, pH is low and PaCO2 is high. Metabolic alkalosis and acidosis both show equal changes in pH and bicarbonate. Now let's go over the steps for solving ABGs using the tic-tac-toe method. First, know the normal ranges. pH, 7.35 to 7.45 PaCO2, 35 to 45 millimeters of mercury, HCO3, 22 to 26 milliequivalents per liter. Make a tic-tac-toe grid with acidosis, normal, alkalosis as columns. Place each value, pH, PaCO2, HCO3, into its correct box based on where it falls. Circle 3 in a row if it's PaCO2, respiratory. If it's HCO3, metabolic pH tells you whether it's acidosis or alkalosis. Then check compensation. If the value not in the 3 is normal, uncompensated. If it's abnormal, check the pH. If pH is normal, fully compensated. If pH is not normal, partially compensated. Let's work on solving a few ABGs so you can get the hang of it. Practice again before your next exam. Now let's talk about oral electrolyte replacement. This is mainly used for mild fluid and electrolyte deficits. Oral solutions usually contain water, sodium, potassium, and glucose. The glucose not only provides calories, but also helps sodium and water absorption in the small intestine. Commercial oral rehydration solutions are easily available for home use. It's important to avoid drinks like cola because they have poor electrolyte content, and the excess sugar can actually cause osmotic diuresis, making dehydration worse. And next, let's look at IV fluids. IV therapy is used in two main ways. Maintenance therapy, when oral intake isn't possible, like during surgery. Replacement or corrective therapy, to treat existing or ongoing losses. The choice of IV fluid depends on daily needs, lab values, and the fluid's tonicity, whether it's hypotonic, isotonic, or hypertonic. Tonicity is the key factor guiding fluid selection. Fluids are divided into crystalloids and colloids. Colloid solutions contain large molecules that raise oncotic pressure and pull fluid into blood vessels. Crystalloid solutions are water with electrolytes. They replace fluids and maintain balance. Examples include normal saline, lactated ringers, dextrose in water, and dextrose in lactated ringers. Now let's review the nursing management of electrolyte and acid-base imbalances. First, we must assess the patient for signs and symptoms of imbalances and identify potential risk factors or causes. If needed, we should be ready to initiate resuscitation protocols and provide respiratory support. Management may include giving intravenous fluids, medications, or a prescribed diet, and treating any cardiac dysrhythmias according to policy. We also play a vital role in obtaining lab specimens for electrolyte levels and ABGs. Safety is a big priority. For patients with neurologic or neuromuscular problems, we must implement fall and seizure precautions. We should also monitor for complications from both the imbalance and the treatment. Nursing care also includes orienting the patient if confused, helping them balance activity with rest, managing side effects of electrolyte therapy, and evaluating their response to treatment. In short, our role is not only correction, but also support, safety, and continuous monitoring. Now that we've covered the nursing management of electrolyte and acid-base imbalances, it's time to move on and discuss central venous catheters. These devices are essential for patients who need long-term intravenous therapy, rapid fluid replacement, or frequent blood sampling. Let's take a closer look. Central venous access devices, or CVADs. These are specialized catheters placed into large blood vessels for giving medications, fluids, blood products, or for blood sampling. There are three main types: centrally inserted catheters, peripherally inserted central catheters, or PICCS, and implanted ports. Each has its own specific indications, advantages, and considerations. Let's look at the different types of central venous access devices in more detail. First, the tunneled central venous catheter, where the tip is positioned in the superior vena cava for long-term access. Next, the PICC line, which is inserted through the basilic or cephalic vein and advanced into the superior vena cava. Finally, the implanted port. This is placed under the skin and accessed using a special Huber point needle. The needle's angled tip prevents damage to the port's septum. Ports are especially useful for patients needing long-term therapy, such as chemotherapy, since they remain hidden under the skin when not in use. Now let's go over assessment and care for central venous catheters. First, during site assessment, we always check for redness, edema, warmth, drainage, tenderness, or pain. Any of these may indicate infection or complications. Next, dressing changes are typically done every 7 days unless the dressing becomes wet, soiled, or loosened. The key steps include strict hand hygiene, gathering supplies, using clean gloves and mask, removing the old dressing, and assessing the site. Then, with sterile technique, cleanse the insertion area for at least 30 seconds. Allow it to dry and apply a biopatch if indicated. Finally, place a sterile occlusive dressing and label it with date and time. Injection cap changes are also usually every 7 days or sooner if the cap is used for blood draws, becomes contaminated, or damaged. For catheter patency, flushing is essential. The frequency depends on the device and agency policy, but commonly every 12 hours or before and after each IV medication. Use the push-pause technique with a 10 milliliter syringe of normal saline. Some catheters may also require a heparin flush to prevent clotting. The overall goal is to maintain sterility, prevent infection, and ensure the catheter remains patent for safe and effective use. Some important complications of central venous access devices. First, catheter migration. This can happen due to improper suturing, forceful flushing, or even spontaneously. You may notice sluggish infusion, difficulty aspirating, or edema of the chest and neck during infusion. The catheter may also appear longer than before. In this case, we prepare for fluoroscopy and assist with removal and replacement. Second, embolism. This may occur if the catheter breaks, a thrombus dislodges, or air enters the circulation. Symptoms include chest pain, shortness of breath, tachypnea, hypoxia, cyanosis, and a sudden drop in blood pressure. Management involves immediately applying oxygen, clamping the catheter, placing the patient on the left side, and notifying the provider. Finally, pneumothorax. This can result from accidental perforation of the pleura during insertion. Signs include absent or decreased breath sounds, dyspnea, chest pain, cyanosis, and unilateral chest distension. Management includes applying oxygen, positioning the patient in semi-Fowlers, and anticipating chest tube insertion. So remember, careful monitoring and prompt response are crucial when managing CVAD complications. I hope this session has helped simplify some of the complex topics and given you practical insights you can carry into your practice. Thank you all for your attention and active participation. Your engagement truly makes these discussions more meaningful.